Hello everyone, this is the LensHooke Seminar and it is going to be start after 5 minutes. Do you want to say hi? Hi to our global customers.
Good afternoon, ladies and gentlemen. Thank you for taking your time to join this seminar, and sponsored by Agarwal Corporation, who is the male infertility total solution provider for Taiwan. It's our honor to invite professors, Professor Giovanni, Colpi, and Professor Ashok, Agarwal, for our seminar today. Allow me to introduce Professor Giovanni, Colpi, as our moderator. Professor Colpi. The professional experience. He is now the head of Andrology and scientific director of Infertility in Switzerland. And he is also an andrologist in IVF unit in Swiss Fertility Center. And he used to be the scientific director of Andrology and IVF department in Milan. And he was also the head of Andrology and the IVF department at San Hospital in Milan. In terms of his scientific activity, he is now full academic of the European Academy of Andrology, and also is a member of the committee for the guidelines on OAT of EAA. So let's welcome Professor Colpi for our moderator.
Dear colleagues, I am very pleased today to open this seminar where really truth and reliable innovation in andrologic field will be presented at your attention. Exactly 2 years ago, just to make an example, about the topic which will be presented today in Ashok and co-workers in a review on the journal of sister reproductive genetics wrote, despite several studies already published, the use of artificial intelligence within assisted reproductive clinics is not yet a reality. This is largely due to the different artificial intelligence techniques that are being proposed to be used in the daily routine of the clinics, which causes some uncertainty in their use. Several databases were analyzed in search of articles where applied artificial intelligence algorithms were used on reproductive data. From the proposed algorithm, most have achieved a satisfactory precision, demonstrating the potential of a wide range of artificial intelligence techniques. However, the evaluation, this is 2 years ago, the evaluation of these studies suggests that the need for more standardized research to validate the proposed models and their algorithms. And they easily spelled out a prophecy. Routine use of artificial intelligence in assisted reproductive clinics is just a matter of time. Well, the time has arrived, and the first application of artificial intelligence in the field of reproductive medicine are available nowadays. And we are talking about instruments which are really efficient and effective, able to reliably help us in our daily work, saving our time and guaranteeing in almost all cases the highest precision that what we obtained manually. This first application will be presented now by Professor Ashok Agarwal. And I am really honored to introduce Professor Ashok Agarwal to you. A friendship and a mutual esteem lasting more than 30 years binds me to him. Okay, Professor Ashok Agarwal was a former assistant professor of urology at Harvard Medical School, was appointed in 1993 by the Cleveland Clinic Foundation in Ohio as the head of the Clinical Andrology Center, which over 30 years under his leadership had become a center of excellence in the United States for the diagnosis of young fertility and fertility preservation. He served as a chairman of the board of the American College of Embryology for 3 years and was the recipient of several awards from the American Society of Reproductive Medicine in the latest years, teaching awards from the Case Western Reserve University of Medicine for 3 annual summer and for the training program and advanced reproductive. He was recognized by the American College of Embryology as the IVF Expert of the Year for 2019 and recognized for his innovative online education initiative during the pandemic by Fiber Scientific Society. He published over 855 scientific papers and review articles in various scientific journals, authored over 225 book chapters, presented over 1,830 papers at national and international meetings. His search index is presently 149 on Google Scholar and 111 on Professor Agarwal is ranked as the first author in the world in the field of male fertility and human assisted reproduction in focus, based on this number of peer-reviewed publications, citations, proofs, and PhD. He is an editor of over 45 medical textbooks, manuals related to male fertility, assisted reproductive technology, preservation, and antioxidants. Is the editor of 14 special journal issues and board member of 13 international journals. Has trained more than 525 best scientists and clinical researchers from the United States and more than 55 countries. He ideated during the pandemic an online training in andrology and human assisted reproduction, where over 5,000 participants from more than 80 countries have received their training and certificate. His research interests are in identifying biological markers of oxidative stress, DNA damage, and apoptosis using proteomic research tools and bioinformatics analysis, and his current passion is to direct advanced online meta-analytical research from universal topics in fertility and human reproduction by involving clinicians and researchers from around the world under the banner of the Global Andrology Forum, a forum founded and led by him, which nowadays collects 370 scientists and clinicians from 60 countries. Please, Professor Agarwal, to introduce your lecture.
Thank you very much, Giovanni. Good afternoon, ladies and gentlemen. Thank you very much for coming to this session. It was not easy to find this place. It required quite a bit of expertise, and I had two people guiding me to bring this to the labyrinth of tunnels and places. So I'm so happy so many of you could make it, and I hope you will enjoy the program. So I want to thank the organizer, Honorable company from Taiwan, and their principal, Mr. Brown, and Sherry, and Kevin, and so many of them who actually helped put the program together. So thank you, Giovanni, for very infertility, why we are talking, male infertility remains one of the most important causes of infertility around the world. For a long time, there was a lack of attention on male infertility, and the focus was always on the woman. But we have seen a radical shift over the last 10, 15 years, where physicians, the clinicians, the reproductive physicians, and the scientists are finding that male gamete plays an important role, and they are realizing that even after 40, 50 years of IVF, we haven't really dramatically changed our success rate for IVF in ICSI. They haven't really risen to the level that should have. If you look at the registry for ASRM or eshre, the fertilization rate and the success rate for IVF and ICSI have increased only incrementally from last 10, 20 years. So they haven't gone up dramatically. I'm talking about the actual pregnancy rate and live birth rate. I'm not talking about just the fertilization rate. So, and there is a host of factors that dictate the success which really matters to the patient, which is having a normal, healthy baby. And I feel that by excluding the male, what has happened is, or not paying enough attention on the male partner, what has happened is that the success rate of IVF has really stayed far below than what we would like to see. We would like to tell the patient that you have 100% chances of success in terms of having a baby. So we are going to charge you $10,000 US, and we are going to guarantee that you are going to have a baby. But certain such type of promises cannot be made because the reproduction is a very complex event. So what I meant to say is that the field of andrology is gaining attention because we have reached to a point where the success rate by excluding the male partner is really not going to rise any further. So there is a realization all over the world that andrology needs to be taken more seriously. There are a lot of things that in andrology has been traditionally far behind in terms of their time, and the technology had not really entered into that phase. So that is really slowly changing. So male factor infertility, whatever side you believe, is a big problem, and I think it has been a problem, but there is a greater realization among many of our clinicians and researchers that almost half of all causes of infertility could be linked to the male. Now, whether you look at more strict definition that maybe 20-30% of causes are due to male partner, but even in the other 20-30, there is involvement of both male and female. So if you look at the total number of cases of infertility, it is estimated through our publication could be over 100 million couples where male partner plays an important role, or male factor is one of the important causes of infertility. The male infertility is increasing because of a number of causes. As we realize, there are societal causes, there are environmental causes, which is really driving up the issue of infertility, not only among the female, but also a lot on the male side. So we are realizing through a large number of publications that male fertility is really increasing all over the world. It's not a regional phenomenon, it is a worldwide phenomenon, and there are so many studies that have been published in the top-rated journal, which seem to indicate that the fertility has been declining over the last 40-50 years in a very significant manner. So, and it is not related to a single region. So it is not a problem of developed countries, it's not a problem of wealthy countries, it's a problem which is global in nature. So how do we really go about looking at problems of male infertility? So I want to change here. The first thing that is done during the examination, after the physical examination and history, is to order a semen sperm, whether those sperm are present or not present, and if they are moving, if they have enough sperm. So it really is not telling whether the man is fertile or infertile, but it is telling whether they are, it is producing the sperm and whether they are having enough number of sperm of normal shape or have enough sperm which are motile. So this test has not really changed in a long time. This test has been going on for almost, I don't know, maybe Giovanni can tell, maybe 100 years. The same type of test, although we have from last 50 years, World Health Organization have published and produced these WHO standards for guiding the laboratorians and clinicians on how to conduct and interpret the results of semen analysis. But the test itself is very complicated, and even though it is misconstrued as a very simple, easy test, to do it in a reliable fashion is really very difficult. Even for the same individual to be able to repeat and reproduce the results of the semen analysis is very difficult. And it has been said in papers that almost 95% of the labs in the US is not able to conduct the semen analysis correctly, or they make a lot of mistakes. So even though it is a simple test, but it is characterized as a complicated test according to the guidelines within the CLIA or within the certifying agency or the regulatory agency in the United States. So in the figure that you see here, a semen analysis is basically a macroscopic exam and a microscopic exam. It tells essentially under the microscope some basic parameters of the semen. It tells about the concentration, motility, total motility, progressive motility, morphology, etc. So these are the basic tenets of semen analysis. Semen analysis does not always tell the entire story. There are things which the semen analysis of the microscope cannot see. So those are beyond, and those are the types of functional properties of the sperm that require special investigation or advanced tests. And those tests could be a number of tests. There are some which are described here in this cartoon. Reactive oxygen species, sperm DNA fragmentation, etc. So those are the types of tests. This is just a small example of advanced tests. There are a number of tests which are listed in the WHO 6th edition, which was just published last year. So that guidelines actually provides a list of advanced tests that are available for clinics was in 2021. As I said, it's called the 6th edition. But to really read the 6th edition, I mean, if you look at it, it's a humongous book, almost 300 pages. And to read and understand it, it takes a lot of effort. But it is a highly subjective test. When you're doing the semen analysis, it's very hard to be able to do it unless you have been very well trained to do it in the correct way, which is reproducible and accurate. So it is a test which is subjective. I mean, it is just made up for a test which is highly prone to errors. And there is nothing you can do unless you are performing the test, you are very well trained, you are a single person and you have a small lab. But if you have a busy clinic, it's really a challenge how to train multiple people to conduct this test in a reliable, reproducible manner. And that is why this test is regulated in the United States. And it requires a great deal of training and then quality control, quality proficiency testing requirements. We wrote a paper a few years ago where we looked at this test and to see why this test is really unreliable. And this figure really documents or kind of provides a snapshot of the reasons why this test is so difficult to provide correct result. There are so many variables that are moving parts that it's very hard to control. Especially within the clinic or between the clinics, it is very difficult to really see the results that you get from, for example, from Professor Colpi's lab to Professor Florence Wojter's lab. The test results could be completely different for for the same men that had a semen analysis. So there are so many things which go into it. There are biological variability within the semen itself. The testis produces the sperm in waves, and also there is variability because of the various types of devices and inter and intra-individual variability, which is between the individuals or within the same individual. If they repeat it 2-3 times, you will find totally different results. So this test has been right for a long time for automation, as the results of the test performed manually, which is considered by WHO as the gold standard, but to perform that test is very difficult for most of the clinics. So let's talk about artificial intelligence for a second. It is something that has been discussed or talked about for a long time, and you can see through this cartoon, right from 1950, there has been interest in terms of artificial intelligence, but it really is more in the last 30 years that the issue of artificial intelligence, not in andrology but in general. We learned about machine learning, where of course there are computer training of the databases that are fed into the computer by individuals, and then that actually allows the machine to help identify certain features correctly. And I'll come to that in the next slide. And then the deep learning, when there is enough data which has been entered into the system, into the computer system, then it starts automatically making the decisions correctly. So it is a step-by-step process. This is something that takes time, but ultimately deep learning is what really allows even more accuracy in the results that the machine can generate. So how does it work for semen analysis? We enter the results, for example, if the patient is, let's say, have athenospermia, you enter the results of patient with oligospermia or patient with keratozoospermia. So you have certain characteristics to say that this patient is athenospermic, and then there are sperm samples which are normospermic. So you will enter those type of databases or data into the system, and you will tell the system which is really athenospermic, which is normospermic. So if you add 10,000 or 100,000 of such data into the system, that is how you will be able to then have the machine identify what is the parameter which is normal, and which is abnormal according to the defined characteristic that have been fed by the operator. And this is part of the machine learning. And in the deep learning, you put the data into the system, which is already defined, and then it basically has a system or algorithm which will allow it to continuously learn and improve its ability to identify the features that are of interest to the researcher. So it will be able to provide the output on its own without really being prompted so there is no need for further machine learning ability, because the data has become mature. If you have added enough amount of data to provide the reliability of output which is very high. And this phase is called the deep learning. So the deep learning technology would really eliminate human error, and that is how it is considered. In terms of semen analysis, the next progression after manual analysis about 40 years ago was the development of GASA system or computer-assisted semen analyzer. These are semi-automated machines which really are more like a machine learning type of devices, which require significant input from the operator, and with the program that they had, they were able to identify the sperm by shape and brightness and various other characteristics as actually sperm, and then provide various data in terms of the concentration, motility, morphology. These are some of the systems that are already being marketed, but there are so many other devices which have come and gone over the last 40-50 years. So these devices are collectively called computer-assisted semen analyzers. These do not have the element of artificial intelligence in a real sense. What are the limitations? They are very huge. I mean, most of them are. They require trained person to operate the device. That is a must. That you need a highly trained person to operate, or they need to know how the system works. You cannot have anybody and everybody use that. And there is a variation in inter-operator results if it's not done correctly, and it requires considerable amount of time to report, and most importantly, they are quite expensive. I remember some time ago when we were buying a system, an average system would cost $50,000 to $60,000 US. And I don't know what surprise these days we have several of these systems that we bought. But they require constant update and maintenance, which is very expensive. So there is an upfront fee, and then there is a fee for maintaining them and keeping them up to the standards, because they become outdated very soon. So if we look at the real computer-assisted semen analyzers versus the artificial intelligence incorporated device, which is produced by Bonraibo about 5-6 years ago. This is an example of the device which we are going to talk. So this is a small device, and you can see an example of it on when you exit the program. And this is an example of the CASA system. I mean, all of them are different, but this just gives you an idea of how big a system is. So the difference between the X1 Pro, which is an AI-based semen analyzer, a very small, compact, just a little bit bigger than the iPhone, and traditional CASA system is huge. So if you look at the traditional CASA, it takes the image, it has adjusts the parameters to get the clear image, and then there is an algorithm. Manually, you have to double check the results, because you cannot be always sure those results are going to be correct, and then it generates the report. Unlike in X1 Pro or AI-based system such as LensHooke, it really is very fast. There is really no human interface here. You have the semen drop, you enter it into a cassette and load it into the port of the device, and then essentially it does everything all by itself, and within 4 minutes or 3 to 4 minutes, it will provide a report. So there is really nothing that you have to do, and the best part is that it is really very fast. So let's learn more about it a little bit. This instrument has been used, and we validated this in our clinic at Cleveland Clinic, and published some very good results 3-4 years ago. But if you look at the actual working of the instrument, there are only 3 steps. It takes 2 to 5 minutes. It does everything that you require. It has a pH, concentration, motility, and morphology. The steps are: you put a drop of the semen as well as a drop of pH. So there are 2 drops. There are 2 parts here for taking the semen drops. And then essentially insert the cassette here. And the third step is wait for 3-4 minutes for the report to come in. And the best part is that the measurement range of each parameter, the pH range is between 6 to 8, concentration between 100,000 is pumped to 300 million, total motility, progressive motility, non-progressive, it can go from less than 1 to 100%, and morphology by strict criteria from less than 1 to 100. So it's a full rate. You can examine the highest concentration samples without dilution. These are some of the biggest problems with traditional CASA, of course with the manual, is that when the sample becomes very concentrated over the concentration of 60 or 80, 100 million, you have to dilute and you have to test it after only dilution. But this is not needed in this device. So there is a video, I think, to introduce you to this particular technology. It's only about 30 more seconds. How do I play this? Lucas, would you help?
I think you just turn off the presentation slide and open it again.
Sorry about that. Well, this is the paper that we published, which documented the validation of LensHooke X1 Pro and computer-assisted semen analyzer, which we use the Hamilton-Thorne device that we use for our patients there at Cleveland Clinic, and compared 3 ways. The third one was with laboratory-based manual semen analysis. So I'm going to show you a little bit of those results in the next few slides. So the most important feature, the conclusion of this was is the use of AI to recognize the sperm, analyze their movement, and define if they have normal or abnormal morphology. The algorithm in X1 Pro uses WHO 5th edition and machine learning technology to train the system for its highest accuracy and reproducibility. And these are the results of our correlation between manual semen analysis and X1 Pro and Hamilton-Thorne IO system. So here we had results from 100 patients which were oligospermic, esteno, normal from both patients and donor, and we conducted each semen samples 3 ways. So manual semen analysis by X1 Pro, correlation by Semen are described here, and you can see a very high degree of correlations here for manual versus LensHooke, where manual semen analysis was done by a trained andrologist using WHO protocols, and almost all the parameters showed significant correlation. Same thing goes for manual versus Hamilton-Thorne IOs, and then LensHooke versus Hamilton-Thorne as well. So these are the results that you can see here. Now, inter-observer agreement, which is really an issue in terms of the laboratories, technologies. If you have 5, 6, 10 people working, how do you really make sure that anybody and everybody can cross-cover and do these tests if other person is not available? So this is quite a challenge in most of the clinical labs where you have a lot of volume and you cannot depend on one person to do all the testing that is required. So inter-observer agreement is extremely important. And this was analyzed in 10 samples and by 3 different individuals, and you can see the inter-observer correlation was pretty high for the device for LensHooke. Also, we looked at the performance of manual semen analysis versus X1 Pro. We looked at many important parameters such as the cutoff value, which is through the WHO, and looked at the sensitivity, specificity, positive predictive value, and the negative predictive value accuracy. So most of these parameters were very, very good. What was not good was the positive predictive value of the morphology, but the negative predictive value was very high for morphology. Sorry. So based on the data, we proposed, since the test has a very high negative predictive value of 98%, if the cutoff, if the test results are 4% or above, then no further evaluation is necessary because the test results are pretty good. But if the test shows sperm morphology less than 4%, then it should be confirmed by manual method. And that cut down the amount of work that is needed in terms of a routine semen analysis. So in terms of how this can be done in a real setting, so interpretation of test results, if it is more than 4%, go ahead and you can report. If it is less than 4% for morphology, then the technologist should repeat the morphology and confirm those results manually. What are the unique features of this device for LensHooke X1 Pro? These are some of the key features that we believe. Very easy to use, no training required. So I can promise any of you can just walk over to the device and you can do it in 2 minutes. There is no training required. The same cannot be said for a manual semen analysis. Many of you who are familiar with that know it requires enormous amount of training. There is no training required. Second, space required is really small, which you can see by yourself. The device is so small, you really don't have to create a huge amount of space for its use. Analysis time is incredibly small, only less than 5 minutes. I mean, that is compared to easily 40 to 60 minutes for a manual semen analysis. It does not always include doing the staining and scoring the morphology smear. Accuracy is very high, which I have shown you through the results, and it has a huge range, 100,000 to 300 million. pH is combined with semen analysis, morphology no fixation or staining required, and inter-observer agreement is very high. And the results, the best part of it, as I tell everyone, is that by the time the patient has just come in and walking around and has given the sample, the results are ready. And you can present the results and forward it by Bluetooth directly to the clinician, and they can counsel the patient and tell what is the next step that needs to be done. They don't need to be scored, they don't need to be told, and they are not supposed to call the lab or the physician, where are my results, when will I get it? They get all anxious. The results are all available within few minutes, and the patient really saves another very strong point. So now, this part of semen analysis is one kind of scope of the wheel. Now we go to the advanced test, as we are talking about the total solution. So advanced test is certainly another important part because you don't get all the results from semen analysis. For many cases, you have such conditions which are described requires an advanced test. So according to EAU, which is European Academy of Urology guideline on sexual and reproductive health, they have said that semen analysis is a descriptive evaluation. It is maybe unable to discriminate between the sperm fertile and infertile men. And in this context, they advocated that sperm DNA damage is more common in infertile men, and sperm DNA damage has been identified as a major contributor to male infertility and poor outcomes following ART. And there are hundreds and thousands of papers that have come up in the last 20 years. So this is not something which is to be debated. I mean, there is so much data and clinical studies and research studies that have been conducted. WHO in its 6th edition guideline in 2021 has also advocated that in recent days, from various meta-analysis, they have advocated that embryo development, implantation and pregnancy can be affected because of damage to the sperm or increased sperm DNA fragmentation, and that can impact both natural and assisted reproduction. So I think there is so much bodies of literature and so many important societies and guidelines have asked us all as reproductive professionals to come up with tests for sperm DNA fragmentation or to conduct a test. When do you do that? You do that, there are many indications. There is not one single place, but there are unexplained infertility, IUI failure, repeat pregnancy loss, diabetes, a number of things where conditions under which conducting a sperm DNA fragmentation test will be considered very important. So, sperm DNA fragmentation, the main reasons for increased focus is there is a high incidence of DNA fragmentation in men with idiopathic infertility. Idiopathic infertility is abnormal semen quality, where there are no other identifiable cause in terms of taking the physical and anatomically. There are no other things that can be identified abnormal semen quality, and also where the female factor, there is no female factor which is clearly known. So in this cases of idiopathic male infertility, sperm DNA fragmentation has been found to be a very high incidence. And there is certainly some negative effects that have been considered of using sperm with fragmented DNA. DNA fragmentation has been linked to repeat pregnancy loss. It is also something that can be addressed by using HC instead of IUI. There are other, so test in itself is not just a diagnostic, but it's a tool to manage correctly the patients with high incidence of DNA fragmentation. Varicocectomy is one way for treating these men with high DNA fragmentation and antioxidant treatment or lifestyle changes. There are a number of methods to measure sperm DNA fragmentation, and there are hundreds of publications with various types of techniques. There is all kinds of tests and methods which are there, which are listed here, and I'm not going to go into that, but what it tells us, there is no consensus at this time from any of the professional societies which says that we should be doing this or that. There is no gold standard. So it's like a Wild West at this time, and every test is trying to compete, and every lab, every clinic has a pet test that they believe and trust it. And the problem is because the tests in general are very difficult to be very reproducible. And for average labs to perform these tests in a reliable, reproducible manner, is different because these are not available commercially. These are lab developed tests, and most of the tests are not except for the SCD test, which is the halo test. So let's talk about this complementary dispersion test or the halo test. Halo test is actually one of the techniques or one of the type of tests that the companies offer. The principle is to evaluate the sensitivity of sperm DNA to acid denaturation. It measures both single and double strand breaks. And here you can see the sperm without any fragmentation, and these are normal, and these are with fragmentation. These are abnormal, and these are described here: normal, abnormal. So a small or no halo is bad. Just you have to understand or remember. So DNA fragmentation index is calculated by counting sperm with halos or no halos in this test called sperm probability dispersion test. The shortcomings of the halo test is the inter-observer variability is high, and the reason it's highly subjective. The images are unclear, and only 300 sperm are being counted in this test. So this really affects in terms of how the operator is looking at and is able to identify. So there are unclear halo which are blurred, the core is unclear, and also there is the test kit or the test which is marketed as halo test has a dirty background in many of the slides. LensHooke DNA fragmentation total solution for DNA fragmentation called R10. R10 is a test kit based on SCD principle, and X12 Pro is a device which combines artificial intelligence to read the slides automatically once they are entered into this device. So it can count up to 3,000 sperm, unlike the 300 that the halo sperm test asks for. So this particular device called X12 Pro, which is also available here for you to inspect later on, it has autofocus and XY table, which allows you to examine 50 different fields in total to count more than 3,000 sperm, and if you use manual to examine, you could count only 300. So that's really a big difference. And it is very fast and simple. It takes only 3 to 6 minutes to complete the entire calculation, unlike manually, which may take a lot more time. LensHooke R10 uses the in-gel denature technology, which could provide more clear image, hence it could reduce the manual error to improve the performance. So R10, which is the test kit, combines sample, embedding, and denaturation procedure to shorten the operation time. We have been doing a lot of work we have done in the last 6 months using R10 and X12 in my previous job at Cleveland Clinic just 2 weeks ago. And this includes protein denaturant and ionic surfactants are added to the lysis solution to accelerate DNA loop releasing from protein. The related patent by the company is pending for approval. The modified staining procedure makes it clearer background and a better image. This is the principle of this particular device of the kit that is called R10. And these are the images. As you can see, the one in the bottom are the ones generated by this particular test kit called R10. G2 is the brand name for Hellosperm. So the images are much more clear, as you can see, compared to the other product which is available in the market. the correlations that we see between manual and X12 for R10. So on the top left are the correlation between the manual counting of DNA fragmentation and by manual and X12. X12 is automatic device. So you can see a very high degree of correlation between the two methods, either automated method or doing manually by hand. The second one is the correlation between R10 and DFI by G2. G2 is the Hello sperm. So there again is a very high degree of correlation. And this is then augment analysis. Again, there is a very good correlation. Difference of manual and X12 for R10 and average of manual and X12 for R10. So these results are actually showing very good data. And to summarize this slide, the correlation between R10 by manual counting and X12 Pro is very high. And manual counting has good accuracy compared with X12. The DFI of R10 is highly correlated with G2, and R10 has good accuracy compared with G2. Let's look at the further results. Did I miss this slide? This, sorry. I think I showed it. Sorry about that. There's so many slides. Next is the LCD testing by R10 versus G2. These are the inter-observer results. This entire analysis and testing was done in the last 2-3 weeks before the meeting. So these results are very, very new. So here we are seeing the inter-observer agreement of LCD testing by two methods, R10, which is by LensHooke, versus G2. But the bottom line here is the information here, which shows that the CV of the R10 done by X12 by automated method using the LCD test kit called R10 is very low. It's just 4%, and and compared to the one which is just using the G2. So this is very good news. And sorry, 25%. And when you look at the range, again the range is very low, only 1.7 as compared to G2. This is by automated device, this is by manual method. So the results are pretty good for this particular test kit as compared to a similar type of kit in the market. And these are the summary of this research, which shows both Hello-Sperm G2 and LensHooke R10 have a good agreement for inter-observer manual DFI counting, and LensHooke R10 with X12 Pro Analyzer has the best inter-observer agreement among the three combinations and has the least variation among different observers. Now let's look at the test of LensHooke R10 and X12 Pro versus SCSA. So SCSA is another important test which has been there from the very beginning. It's kind of the leader in terms of the sperm DNA fragmentation testing. So when we look at the comparison of the results of, and it's easier to see the results here, when you can see the correlation, but these are summarized here. So the correlation between R10 manual versus SCSA, which was done in Dr. Evans's lab in Brookings in South Dakota. So these samples were sent and then they were compared with what we conducted at the Cleveland Clinic. And the results are very good if you look at the correlations. And they are also good for G2, which is the Hello-Sperm. So in summary, both R10 testing reading by manual and X12 Pro Analyzer are highly correlated with SCSA. Now, comparison between conventional SCD and R10 are described here, and more important part of it is the part here, which is in the red box. The counting Hellos by X12 Pro, which is a device which is AI aided, is automated, less time it takes, also calculation time, and more importantly, the sensitivity of the test is very high because it allows up to counting of 3,000 sperm, which is the hallmark. Last part of this presentation is the most important because this is being introduced, this technology at this eshre meeting by the company. It's called, it's basically deals with the sperm separation, which is necessary for all kind of ART, whether it is IUI, IVF, or ICSI. So current methods to do sperm preparation include simple washing, direct swim up, and discontinuous density gradient, double density. And if you look invariably, all of these technologies use centrifugation. You cannot really do anything unless you spin the sperm sample and try to get rid of the crud and really have the good quality sperm which can be collected. So centrifugation is an essential part of all sperm preparation techniques. And that is a concern because there have been studies which have demonstrated that the centrifugation is really harmful. It is one which can increase the sperm DNA fragmentation or not decrease the DNA fragmentation from the neat semen into after it has gone through the density gradient. So if you look at these red boxes, and there are a number of studies which have studied it, you can see that the sperm DNA fragmentation in the ejaculate really does not decrease. There is no big difference compared to those. If you look into, for example, in this particular condition, you will see that there is a significant decrease in the DNA fragmentation in SWIM-up, which uses less centrifugation step as density gradient. So there is a significant problem with the current technique. So using the density gradient will have higher or equal value of sperm DNA fragmentation compared to the neat, and sperm separation by SWIM-up can significantly decrease the STF value compared to neat and density gradient. So clearly, I think we know that density gradient, although it is a preferred technique for ART, but it is not without a concern. So centrifugation free market growth is supposed to grow, but the most important part is there are technologies such as centrifugation, sedimentation, and more importantly is the microfluidics, which is a very big thing from the last 7 or 8 years. And there are a lot of products which are out in the market catering to the ART market. So the disadvantage of microfluidic based device, at least from the literature, is that the low volume of yield, the cost is fairly high. It can cost as much as $100. Still not standardized. And the more important part is the data is inconclusive in terms of ART outcome. And what is there is that it does talk about embryo quality improvement, but it really shows no data on terms of fertilization, clinical pregnancy, or live birth, which is really important. So LensHooke came out with this system, which is they call as sperm separation solution, or CAO. This is the product name that they had given. So it is really an easy system to use. It takes only 4 steps, from adding the sample to adding the wash media, putting it into the incubator, and collecting the sample. It is very fast. It really, you can spend almost an hour when you do the density gradient, but with this system it takes less than half of the time. And it uses a special type of filter membrane which allows healthy sperm to swim up to the upper layer. It does not require any step of centrifugation, so it's very natural, and it would prevent the cause of DNA fragmentation. Now we have to prove what we are saying, and I will show that in our data. And this is a technology slide, patent pending, in terms of its device, in terms of the membrane which are there. This is the membrane which has pores. It allows the sperm to swim up through the petri dish, which is a special type of petri dishes that have been designed. There is a video which they will show later on, I believe. So let's look at the data, which is really exciting. Performance, where we looked at the total motility, progressive motility, and rapidly progressive motility. And the green bars are the results of the neat semen. These are without any kind of intervention. And the yellow is after sperm separation using CA0 technology. So you can see that there is a significant improvement both in samples which are characterized or categorized by normal spermia or abnormal in both categories. There is a significant improvement in all the important semen parameters, total motility, progressive motility, as well as rapidly progressive motility. So we can conclude from this that from this diagram that LensHooke can efficiently separate the high quality sperm with better total motility, progressive motility, and rapid progressive motility of normal and abnormal semen. Next, we want to see the morphology, the DNA fragmentation, and the debris removal. And this is through the morphology results. As you can see, there is again a significant improvement in the results, both in normal and abnormal, in terms of improvement in sperm morphology. Furthermore, the DNA fragmentation was significantly reduced after use of CA0 compared to the new semen, and also the debris removal was significantly successful using this technology. Let's summarize this part of the figure. So it can efficiently separate the high quality sperm, including the high normal sperm and debris removal rate, and result in low sperm DNA fragmentation. Let's look at further. This is a little bit busy slide, and I want you to pay attention to the slide with the colors. So the green bars are the neat sample, the orange is density gradient, and the blue are the zymote, which is the microfluidic device, and CA0 is the one from LensHooke. So there's a lot of dots and p-values here, and I'm going to summarize it later on. But here we are looking at different comparisons. We are comparing density gradient versus zymote versus CA0. So it will be easier. And we looked at an abnormal sample, which are oligospermic, asthenospermic, teratospermic, and OAT. But if you look at the actual yellow results here, in yellow, which summarizes everything, density gradient in zymote, comparing to density gradient in zymote, LensHooke can efficiently separate the high quality sperm with the best motility related parameter. So if you look at the data, which is going to be shown later on in a simple table, even the comparison between zymote compared to CA0, which is the microfluidic device, also does not use the centrifugation, but in terms of the technology, this technology provided better results. So this is significantly different. Here also progressive motility is significantly different. And this is a side-by-side comparison between the two devices. So let's look at the morphology, the debris removal, and the DNA fragmentation. I think the second figure is for DNA fragmentation. This is mislabeled, I believe. This should be DNA fragmentation. So here I think if you look at the results, let me summarize the results, which is here. The CA0 can efficiently separate the sperm with the highest normal morphology rates. So you can see the morphology results are significantly better compared to zymote. So here are performance characteristics between density gradient, zymote, and CA0. And we had about 23 normal spermic and 27 abnormal sperm. If you look at the performance of the results for motility, morphology, DNA fragmentation, and debris removal, the CA0 provided the best results in all circumstances. And we also looked at the inter-observer agreement. There are only a few slides left. After this, I complete in maybe 2 minutes. This really is the inter-observer to see what kind of differences are there between the operators. And the results are very, very good in terms of what we see here. There is a high degree of the sperm separation has a full agreement for both inter-observer and intra-observer operation. So this is very important for the laboratories which are conducting these tests, is to know that the test is reliable if the person repeats it many times or between the different individuals. In comparison between density gradient, Zymote, and CA0, Zymote is microfluidic based technology. If you do a side-by-side comparison, I think it makes it easier to understand the three different things in terms of this is centrifugation based, which is a concern because of either there is no decrease or there is office DNA fragmentation or it causes some increase in DNA fragmentation compared to microfluidics or natural selection by CA0. Technical protocols are fairly easy here, and time-wise both are comparable. The cost is expensive, is still for Zymote compared to it's half of the cost for CA0. This is the total solution, which was the title of my talk. So we started with the AI-powered semen analysis called X1 Pro. This came out, I believe, in 2017. And then it progressed this to second step, which is this one, in last year with the R10 test kit, which is SCD based, as well as the X12, which is AI-powered reader for reading the slides of SCD test that is performed. And this year they are introducing this technology called CA0, which is a sperm separation. It's an advanced test. So the take-home message here is the new AI-powered optical microscopic device X1 Pro as well as X12 Pro has high level of precision and agreement compared to manual methods. X1 Pro and X12 Pro is a fast and simple to operate device that offers reliable and reproducible results. The results of X1 Pro for sperm concentration, motility, and progressive motility correlate very well, very highly with manual semen analysis performed by a trained person, by an experienced operator. The results of X12 for sperm DNA fragmentation correlate very highly with manual semen analysis performed by an experienced operator. Further, LensHooke R10 test can be used for SDF testing due to its good agreement with commercially available HelloSperm G2 test and SCSA. LensHooke CA0 is a fast and simple to operate device that offers excellent performance compared with density gradient in Zymote, especially for abnormal sample. LensHooke offers the complete solution for male infertility from basic semen analysis to advanced sperm DNA fragmentation to sperm separation solution at this time. So the technology is really progressing and in a field of diagnostic andrology where things have been so much behind everything and it was so archaic. So I believe this is very promising. Being in the field for the last 40 years, I think this is the golden time of diagnostic andrology, and I believe this is the start of this phase, and many more companies and many more products will come into the market, making it so much easier to diagnose the problems of infertility in male. So with that, I want to thank all of you for listening, and I believe I am a little bit over the time. Thank you very much.
Agarwal. So now we can open the last part of this seminar with the questions and answers. Yes, please.
Hello, so thank you very much for your very comprehensive and informative presentation as usual. I'm Shanaz from United Kingdom. If you all know, and you correctly said that male infertility is increasing, and the technologies are still far test. So what do you think, what should be the step forward? Because it's very restricted only for private sectors, and it's very, very important key factor in assessment and fertility outcomes. So what should we do? What should we go forward with?
Well, thank you very much, Shahnaz. This is a problem for some countries where regulatory bodies probably need to be convinced about the importance of these tests. I mean, I'm not the right person to address this. This probably will be happening behind the scene. I'm sure a lot of people are working to change that. That these tests should be offered. All clinics and labs should be able to offer these tests freely. These are important tests. For God's sake, I mean, these tests need to be made available. There is so much more that we need to offer that we are not, because we are lagging behind in technology. But in terms of the particular scenario in your own country, I think the important thing is that the physicians need to be educated, and they need to petition the government or regulatory bodies to make these tests available for all the private physicians, for all private clinics. They should be offered. We have no such restrictions in the United States for this type. Did I address your question correctly?
Yeah, the big concern is that the majority of the population is under NHS. We are unable to offer it under NHS. So I suggest some guidelines have to be nice guidelines or right colleges that this is a mandatory thing. So we all need to work collaboratively to persuade them to do this.
Well, I mean, this is really, I think, something that should be done. And, this is the best year to ask the Queen. Maybe she will do that, right? I mean, I don't know what to say here. Maybe Mike can tell something about this. This is his area.
Yeah, I mean, certainly, I think we do need to lobby to get these advanced tests through.
Can you speak up, please? Can you use the microphone? Maybe identify yourself a little bit.
Please, can you tell your name and country, please?
Yeah, it's Michael Close from the UK. So I agree with Shahnaz, is we do need to lobby the governments to get these advanced tests through, but generally you can only get newer technologies through when you've got a health technology appraisal and you've shown cost effectiveness that these diagnostics can actually help and improve a care pathway. Without companies progressing through those processes, they'll never get the light of day, they'll never change the guidelines that are in place. So as a company, we are trying to do that.
Thank you very much. Lawrence, you always have many questions. Come on, you can ask.
So thank you very much, Ashok and Giovanni. And I think it takes probably 40 years and a great deal of knowledge to make it so simple. So thank you. Seemingly simple. But here's the question. So, as you know, the microfluidics, particularly the Zymote, has gathered quite a lot of popularity. Some clinics are using it almost routinely, I think believing, and I'm sure they do believe, that it makes a difference. We've been looking at DNA fragmentation in patients with proven subfertility or infertility, who have had their varicoceles treated, who've had as much as we can do about oxidative stress, organisms treated. So these are the really hardy patients who we just can't improve. Now, here's the question. On the other side of the Zymote, in somewhere around 15 or 20% of these men, the fragmentation is actually worse. And we got progressively motile sperm getting through, perhaps not as many as sometimes do. But I have thought about this very deeply. It's really very worrying. I don't worse fragmentation after zygote. Unexpectedly, unpredictably.
You got me there. It is supposed to reduce or at least not increase. So this is certainly surprising because zygote does not involve any kind of real shaking or centrifugation. So it's pretty gentle, just like CA0, which is a completely natural way of preparing the sperm sample. It's basically hard to imagine how and why the DNA fragmentation can increase, because it takes quite a bit of biological stress for a fragmentation to show its effect in sperm which are already produced. It doesn't happen instantly. So I don't know, I'm not sure whether the test results are reliable. There could be technical problems with the test which could contribute to this type of issue, but there is no logical explanation to see that zygote will lead to higher DNA fragmentation. Yeah?
Hi, Ashok. We actually conducted a little bit of work in that area, and I think one thing to really bear in mind is the type of sperm media that you use when you're using any of these separation devices.
Right.
Because if you can't control for oxidative stress or ORP in those samples, you can find that the sperm wash can link to the sperm, even though you're going through the sperm prep. So you need to control the environment, both in the incubation period, and you need to check if you're using bicarbonate-based the sperm wash that you're using is CO2-based incubator, and you've got to control that quite carefully. So sperm wash media, when you're using these devices, is really important to take some notice of.
That's a very good point, Mike. I agree.
Other questions?
Another question? Yeah, here.
Maybe just a quick question about how much sperm do you get there? So there are there are several ways to purify the good sperm, but I don't recall mentioning what percent of sperm you get. So is this new technology give us more sperm or less sperm than that technology? Is it sufficient for the procedure that we need to do?
That's a very good question, Tomer. I think the technology for CA0 involves layering about a milliliter of semen. So the sperm that you are able to collect are enough for conducting IVF ATC. I'm not sure, maybe Sherry or somebody can tell, are they enough for IUI also, or you have to do another step to collect more sperm, because it only layers 1 milliliter in one of the filters.
Okay, so it depends on the patient's sample status. For example, if the sample is abnormal and with very low concentration, or the motility is very low, I mean the multi-sperm count is not good enough, that might be a big challenge for our products. But if the concentration with the motility is enough, then there is no problem.
Yeah, Ashok, please. Come over in the front. Good.
Hello everyone, I'm Ashok, Agarwal. So you made a point that this method, the lens
X1 Pro for semen analysis. The other two technologies were just introduced. R10 was introduced last year for DNA, and the one for sperm separation just today, I think they are introducing.
Yeah, it's interesting to see that. We should start using that as well as a way to compare it.
Right.
Very useful for you. Yeah, thank you, Ashok.
Thank you very much for your presentation. So I just have a question. So the sperm separation device can be used without samples?
Without samples?
No, without.
So, prior to service.
Oh, right. I don't think we have the data for prior to service. No, it can be done. We don't have the data right now.
Fresh sample, frozen sample, or preservation sample, that is no problem, but we need to we have to do the experiments for that part. But I believe that to do that, I will share more information to finish the experiment.
Okay, so we heard a really important innovation for the also treatment in some cases of male fertility. And so I must thank Professor Agarwal, and I will invite Mr. Kevin Chuang, to close this seminar. Thanks.
Okay, thank you for joining, and I'm sorry there's a technical issue on the video, but we still would like to. Yeah, I think we prepared the video by the file. So if you have time, welcome to stay and look at the video, which is pretty nice, and there's more detailed information inside. And by the way, after the video, you got a voucher. Even you don't have a voucher, please, we have a sample free. You can come to the table with the lady. He will give you the free sample to try about our new product CA0. Okay.
Infertility rates are on the rise. While most of the focus is on female infertility, growing literature points to male factor in more than 50% of infertility cases. Therefore, LensHooke devotes to provide a total solution for male infertility. In 2017, it launched the world's first semen liquefaction test cup, C-cup, the design and enhanced user experience for laboratory technologists. Because of this, it won the Red Dot Design Award in the same year the product was launched. In 2018, the world's smallest automatic semen quality analyzer was introduced. It's easy to operate and offers complete video and paper reports to provide a better communication platform. Nowadays, more than 1,000 global IVF labs adopted this analyzer. In 2021, the total solution for sperm DNA fragmentation testing was introduced. Our unique technology cuts down on 40% of slide staining time, and our patented formula enhances image quality. Coupled with the automatic analysis system, it can test more than 3,000 spermatozoa to provide standardized and accurate test results. By offering this solution, LensHooke covers the important basis for male infertility testing. In 2022, we pioneered live mobile silicon technology to develop the sperm separation device. With just a couple of simple steps, it can select the sperm with excellent qualities. From basic sperm analysis to advanced DNA fragmentation testing, and finally to the sperm separation. LensHooke provides a total solution for the male infertility field. LensHooke, male infertility total solution. LensHooke, the professional of semen analysis, will provide you with a totally new experience of examination. It not only offers you a full automatic exam system, but also a full formula reagent. LensHooke R10 develops the innovative engine technology to reduce 40% test time from 74 minutes to 40 minutes. In addition, the new reagent allows you to make the elaborate sensibility of spontaneous inquiry to reduce the subjectivation compared to manual examination. LensHooke eshre supports 4 USB ports, 1 HDMI port, and 1 Ethernet to allow you to link the barcode scanner, HD1 and Milan. This machine is compact, light, and only takes you 3 to 6 minutes to complete 1 sample examination. The automatic XY tape helps to move the slide to take photos from the different fields. LensHooke eshre allows examination of multiple fields. The professional report provides a lot of detailed information for diagnosis. LensHooke, the total solution of sperm DNA fragmentation, will bring you to the new generation for semen analysis. Technology inside.
Okay, thank you very much, everyone. And we have some, all these new products instruction video will be sent again to your email. And please don't forget to get a free sample. And thank you very much for Professor Colpi and Professor Agarwal. And thank you very much for joining and hope to see you at our booth. Thank you.